Have you ever wondered how a doctor takes a simple complaint, something like a lump on your neck, and turns that into a full-blown diagnosis and treatment plan? Well, today, we're going to get a unique inside look at that exact process. We're going to simulate a pretty intense surgical exam to see how surgeons think, step by step, when the stakes are really high. All right, let's jump right in. It's almost never that single eureka moment you see in the movies. Honestly, solving a medical mystery is a lot more like detective work. It's this careful, methodical process of gathering clues, ruling out possibilities, and then making these really critical decisions. And as you're about to see, something that seems as simple as a small neck lump can turn into a pretty complex puzzle to solve.
So here's what we're going to do. We're going to simulate an oral exam, where a senior surgeon, they'll be our examiner, presents a case to a surgical trainee who will be our candidate. We get to listen in as the candidate thinks out loud, and we'll break down their clinical reasoning every step of the way.
Okay, so here's our roadmap for the case. We're going to follow the candidate through all the essential stages. We'll start with the patient's story, then move to the physical exam, figure out the right tests to order, and finally land on the right surgical approach. This is the exact logical flow a surgeon would use to tackle a problem just like this.
Everything, and I mean everything, starts with listening. So the examiner is about to kick off the scenario, setting the stage for our candidate to start digging for clues. All right, your next case is a 42-year-old female. She's come to your clinic complaining of a mass on the left side of her neck. She thinks it's been growing over the last 3 months. Tell me how you would approach this patient.
A really sharp candidate is always systematic. They'd say, okay, first I would take a detailed history. They'll start with the lump itself, sure, but then they immediately pivot to pressure symptoms. A hoarse voice, for example, is a massive red flag. Why? Because it might mean that lump is pressing on the nerve that controls your vocal cords. Next, they'll check for signs of a hormone imbalance. Is the thyroid overactive or underactive? Then they're digging into key risk factors like family history. And finally, they have to ask about symptoms elsewhere, like bone pain, just in case this problem is spread. Every single question is like a tool in a detective's kit, helping them narrow down the possibilities.
So, the examiner confirms there are no other symptoms and then prompts the next step. Excellent. Now please describe your focused physical examination. Let's see what the candidate can figure out just by using their own hands.
The candidate lays out their exam with real precision. First, just looking. Here's a cool trick. You watch the lump as the patient swallows. If it's part of the thyroid, it'll move up and down. Then comes the hands-on part. By feeling the lump, a doctor can tell if it's hard, soft, smooth, irregular, all of which are major clues. They'll also check to see if the windpipe, the trachea, has been pushed to one side. And of course, they'll carefully feel for any swollen lymph nodes, which could be a sign that something is spreading. This physical exam adds a whole new layer of evidence.
Okay, the initial clues are in. Now our candidate has to use technology to look inside the body. The examiner gives him the findings. Your examination confirms a 3-centimeter firm nodule in the left lobe of the thyroid. What are your initial investigations?
The candidate confidently replies, "My first 2 investigations would be a blood test for hormone levels and a neck ultrasound." The examiner shoots back, "The blood test is normal. The ultrasound shows a heterogeneous left thyroid nodule, which really just means its texture is all mixed up, not uniform. It measures 3.2 by 2.5 centimeters. So, what suspicious features would you be looking for on this ultrasound?"
This is where that ultrasound becomes so incredibly important. The radiologist is hunting for specific warning signs. Things like irregular borders, or if the nodule is solid instead of filled with fluid. Tiny little calcium spots called microcalcifications are another big one. And here's a weird one. A nodule that's actually taller than it is wide is another red flag. Each of these features increases the suspicion that this could be cancer. Based on this checklist, the nodule gets a risk score, which tells the doctors what to do next.
The examiner keeps the case moving. The ultrasound shows several suspicious features, so you proceed with a biopsy. And because that ultrasound looked worrying, the next logical step is a biopsy, using a really thin needle to grab a tiny sample of cells. The examiner gives the result. The result comes back as suspicious for follicular neoplasm. This right here is a classic medical gray area. It means the cells look abnormal, but the biopsy alone can't tell us if it's benign or cancerous. It's an inconclusive result. The only way to get a final answer is to surgically remove the lump and look at the whole thing. So the patient now needs an operation just to get a diagnosis. So with that inconclusive biopsy, the candidate can't just wait and see. The next logical step is a diagnostic surgery.
This is a huge pivot point in the case where the entire goal of the operation is simply to find the answer.
A top candidate shows they're not just a technician. They think about the whole patient. They'd explain that the plan is a thyroid lobectomy, basically removing the left half of the thyroid. But crucially, they'd start by just talking to the patient, making sure she understands why this surgery is needed just for a diagnosis. They'd also check the vocal cords before surgery to get a baseline and arrange all the standard safety measures, like preventing blood clots. It's that kind of comprehensive planning that really defines a safe surgeon.
When getting consent from the patient, the examiner expects the candidate to explain the biggest risks, and with thyroid surgery, that means nerve injuries. Damage to the recurrent laryngeal nerve can cause a permanently hoarse and weak voice. But damaging the external superior laryngeal nerve is more subtle. It affects your ability to control your pitch, so it can be devastating for someone like a singer or a teacher who can't project their voice or hit high notes anymore.
The candidate has perfectly navigated the plan for the first surgery, so the examiner fast-forwards the scenario 2 weeks. You perform an uneventful operation, the patient recovers well, and she's back in your clinic for her follow-up. How do you proceed?
The candidate would say, "First, I would check on the patient and her wound, and then I'd review the final lab report from the tissue we removed. And then the examiner delivers the result. The final report confirms it is a papillary thyroid cancer measuring 3 by 2 centimeters. And there it is. The mystery is solved. It is cancer."
Okay, so the diagnosis is confirmed. This changes the game completely. That first surgery was just for diagnosis. Now a real treatment plan is needed. The examiner asks the final, most critical question. Now that you have this diagnosis, what is your definitive management plan?
Now, before jumping right into another surgery, the best candidates will always say this. The first step is to discuss this case in our multidisciplinary team meeting. This shows they get it. Modern cancer care is a team sport. You've got surgeons, hormone specialists, oncologists, radiologists, all putting their heads together to figure out the absolute best path forward for this specific patient.
After that team discussion, the candidate gives the final plan. Given the size of the tumor, the definitive management would be a completion thyroidectomy. This means going back to surgery to remove the other half of the thyroid gland. This is done to get rid of any microscopic cancer cells that might be hanging around and to set the patient up for any other treatments they might need later.
And just like that, the candidate has successfully passed the station. They took a simple complaint and methodically worked all the way through to a final diagnosis and a 2-stage surgical plan. This case is a brilliant look at how surgical judgment really works. It's not about one big heroic operation. It's a careful, step-by-step process. And for the patient, this staged approach is everything. It makes sure doctors take the least invasive path first, confirming a diagnosis before committing to a much bigger treatment. It's all about balancing safety with certainty every single step of the way.